And I want to thank you all for coming to our meeting today. This is the first quarter meeting for the ORV Transplant Coalition, our first meeting of 2023. Today, this is our agenda for the day. So we're first going to start talking about our ESRD network transplant QI data, interventions that we've currently been working on, and a very exciting upcoming effort that we're doing. We do have a best practice speaker. Dr. Anita Modi from the Cleveland Clinic is going to talk to us today about their work with HIV donors and recipients and the HOPE Act. And hopefully you all can leave here with some great knowledge on that. We do have the Radiant team coming to discuss Radiant study updates, the upcoming data submission. We really would like more Network 9 participation in Radiant. And so we're going to be talking about the study and possibly, if time permits, show the dashboard. And then end it with an open discussion. And we do have some questions that we'd like to gauge the group's interest and participation in some of those areas. Okay.
Before I move on, Carolyn, maybe we could have the person at 1502341 identify yourself for the attendance, just so we have a name. Can you come off a mute, or are they muted because they're a call-in user?
I moved them so they could speak.
Now, who is it? Whoever is dialing in at 1502341, could you just let us know who's on the call, or type it in the chat if you're in a noisy area, just so we can get your attendance? Well, we can try again, Carolyn. I just wanted to be able to capture that person.
Okay, so I'm going to start by sharing some of the transplant progress that we've been doing in Network 9, and then we'll go into some interventions that we've been working on. First, I'll show you guys the waitlist rates. So we're still in the same year since May of data for waitlisting and transplant. The most recent data that we have is from January. I know February should be coming out any day now. But as of January, we are 95 waitlists above where we need to be. So we're doing amazing when it comes to putting patients on the waitlist in our region. We've gotten 1,186 patients waitlisted since May of 2022, which is phenomenal. Transplant is a different story, and I know we've talked about barriers to transplantation in the Network 9 area. A lot has to do with the kidney allocation system, and we've definitely dove into a lot of that back in 2022, and now we're working on things we can affect in light of reduced organ availability in the region. As far as data is concerned, we are below where we need to be for organs, about 340 transplants behind where we would hope to be. And we are still steadily increasing our transplant numbers, just not where we really need to be per the CMS goals. So as we work on increasing waitlist and transplant still in the region, we do have some interventions that we've been doing to try to make some effort in those more problem areas. And so the first thing I wanted to show you is this report card that we've been sending to our dialysis facilities. Now, for any of you that need a refresher on like who our main community audience is, we work closely with the dialysis providers and patients in the network area. We work closely with transplant centers as well, but the dialysis providers are ones that we're consistently doing interventions for and in contact with. And so in January, our intervention all had to do with an inactive waitlist report card. So what this report card is, it's individualized to the different dialysis facilities. We sent this report card out. It indicates the patients that are temporarily inactive on a wait list in Network 9. And so we did provide the UPI number so the facilities could look up the patient in EQRS and find out which patient we're referring to. I do have an example of the report card on the screen. All of the information has
Are you
been
sharing
shared.
something right now, or is it just me? I'm not seeing anything, but I don't know, maybe it's just me.
But yeah, I'm seeing
Son of a gun. Okay.
it.
Do you see our faces? Is that?
Yeah, I see your faces at the top, and I'm sorry, I don't mean to stop everybody. I just only see faces at the top, but then there's like a blank screen underneath. So
Is anyone else having trouble seeing?
I can see the screen of the presentation.
okay, just me.
Wonderful.
Sorry, I didn't mean to interrupt you.
That's okay.
I'll try to figure it out as you're talking.
Okay, and then if there is a continued issue, we'll send the slides out and you can see what I'm describing. So we
I also
went
put a
ahead-
link to them, Carolyn. You want me to do?
I didn't catch that. Thank you. What was that?
I could put a link to the slides in the chat. Let me try to find them. Yeah.
So this report card has the UPIs for the number, or for the UPI numbers for the patients that are currently temporarily inactive on a wait list. It has the transplant center name, the date they became inactive, the transplant center contact information. And then in the yellow section in the middle, we have instructions on how to use the report. So the number one thing that we said when you receive this report is to contact the transplant center at the number provided to confirm the reason for inactive if you're not already tracking why the patient is inactive. And the reason for this being is we really want to promote the communication with the transplant center and the patient on moving them from an inactive to an active status. There's a lot of turnover at the dialysis facility level. And we already know that there's a lot of gaps in communications with patients, especially if they've been on the wait list for a while. The facility might not be aware that the patient's inactive, that there's a very high chance that that is the truth. The patients might think they're active, but maybe they got the phone call and the letter saying they're inactive for whichever reason, and they might not grasp the idea, or they might not know. And so the point of the report is to have some transparency that these patients that are inactive on the wait list, use some quality improvement practices, figure out how you can get them active, and then those patients could receive transplants. And so this was one of the interventions that we did in January to just try to support increasing transplants in the region. The second intervention that we are currently working on right now is all related to a BMI and transplant change packet. So we've heard time and time again that patients are ineligible for transplant for medical ineligibility reasons related to BMI. And moving forward in our CMS work, in the near future, we might be focusing on weight reduction. And we're going to talk about that probably at our next coalition meeting, some of the changes in the contract, once we have a larger scope of like what that work will look like. But we wanted to start focusing on how dialysis providers can support patient weight loss to get ready for transplant. It recently came about where we learned that not all transplant centers have weight loss programs. You know, some of the larger centers have them, but the smaller centers don't. And the dialysis facilities rely on the transplant centers to get their patients through a weight loss program. And the point of the change packet is to disseminate some of that responsibility, empower the dialysis facilities to take more of the responsibility on doing proper diet education, doing exercise counseling, even thinking about alternative approaches such as bariatric surgery, the use of medications. And so what we did is IPRO in the community developed a change packet. It's currently in a draft right now. We haven't finished the publication of it. It includes things such as screening patients for food insecurity, mental health at the dialysis facility level, establishing triage processes for these to help these patients. It also includes implementing culturally appropriate visuals for diet education. I think like the most typical visual education that we see is like a My Plate. It's a standard American diet, but we know not a lot of patients eat a standard American diet. And so we really wanted to push toward culturally appropriate visuals. We shared resources to find food pantries and other low-cost services to help patients eat healthier and to access food. We talked about establishing roles and responsibilities for exercise education at the facility and facility and home exercise approaches that they could implement, as well as exploring alternative approaches, such as medication and bariatric surgery. So this is something really excited about. We grabbed a bunch of community dietitians, did focus groups, asked them what they're currently doing, what they could do. We used a lot of literature review to make this change packet. And so we're excited for this to come out in the near future. And then I'm going to switch this over to Vicki. She's going to discuss, I guess, the most exciting part of this section, something that we're working on right now that you guys are very familiar with.
Yeah, so we're really excited to say that we are taking Transplant Center Compare, which we called it, but now we're just going to call it Kidney Transplant Compare. We're switching the name more for searchability on the web, to a mobile application. So, we've been a long time. You guys all worked very hard with me and the ORV Coalition and Ann to put together this idea of how somebody would be able to look up a transplant center and see the services and the criteria that you have. And we supported that on the website for the last couple of years. And then we had that brief stint where we were going to work with Apex Health, but they were really going the direction of wanting to share that more with facilities than with patients, and really wanted to use a computer-based program, more of a PC-related program. And we thought that's really not where patients are going to be looking, or family members. They're going to go on their smartphone, right? They're going to want to look something up, or their tablet or whatever. So we are now moving and have funded work to begin a patient-facing mobile app. The build is actively underway, so we hope to have it out there and available. Is that like sometime in June, Carolyn? Is that the potential timeline?
I believe mid-April we'll be done building and going into testing. So by June, I think it would be live once we get through some of those stages.
Yeah, so it's really, we do have a user group that we're working with. We will be sharing all of this with you. We hope we can give you a preemptive view so that you can look and use the app and give us any feedback or changes. We have to work with our development team to see if that could happen, but it's going to serve two functions. So not only can they go in here and preview and look and sort facilities, transplant facilities, by their criteria and the services that they offer, but there also is a good amount of education, so they can go and look up resources and some of the things that we've developed, some of the national resources, and they can see that information, as well as information about transplant centers, and it will cover all 13 states in the IPRO networks. And it has the build that it can go nationally if CMS or anyone wants to go forward and fund this, to other states and regions of the country. So we're pretty excited. Did you want to change the slide?
Yeah, I just wanted a quick shout out. Our own Naisha Neal is one of our work group members as a patient. It's really great to have her on the team to make sure that we're keeping the patient perspective when we build this app. And so I just wanted to do a little shout out for her there.
Yeah, thank you. I see that at the bubble. Oh, and Naisha's loving it. So this is the landing page. So we want to try to keep it simple. So they basically have 4 areas to go into. If they're just kind of sorting around and put kidney transplant in and aren't even thinking about a center, they can still find out what a kidney transplant is. And we have a lot of reliable resources under that area. And then if they're more interested in finding out if a kidney transplant is right for them, we have a group of resources there to educate. And then you can start your transplant review. So this is the area that we would contain all the information about transplant centers. And I can't read the last one. Is that the last one, Carolyn? It's not big enough for me.
It was the last one. The starting your transplant journey was living donation and reducing your wait time information.
Oh, okay. All right. Yeah. So that starting your transplant journey was really an area for them to kind of decide between deceased and living, and maybe making some choices about, whether they want to consider a, kind of higher risk level kidney, so that they can evaluate that information before. And then the last part is the review. And then Carolyn's, these are just cut and paste little screen prints we're trying to do to give you a feel of the app. So I know they're really teeny, but this is what they would land on, and they would get a list of resources they could click into and look at and read, in the education center session. So any questions so far? Okay, you want to flip to the next one, Carolyn? So this one, I want to give a disclaimer. Our developers put this together, so we realize that there's not probably a transplant center that would take somebody who has severe cardiac disease, active infection, and tobacco use. They pick the three worst things. So, but this was just their choice, and they don't know anything about the medical world, and so we just used their screen print. But basically, it's showing you can say, what's the zip code that I live in? What area, what mile radius do I want to look to for a transplant center? What are some of the allowed criteria that's important to me? What are some of the support services that are important to me? And people can kind of make those selections, and then they'll come up with a search result. And you can see it like turned back a search result, and it showed you some comparison of the different centers, what they say they, will or won't do in those areas. But imagine that we're not using absolute criteria, because they've made some pretty big absolute criteria to put there, not relative criteria. We have tried to reduce this all to patient-friendly language. So this is all being done with the idea of, culturally sensitive linguistic ability. So we spent a lot of time making the words more patient-related in terms of the criteria. And, what we're hoping here is, they can eventually get, 2 or 3 facilities. Maybe if there's a higher BMI cutoff at a particular facility, that would be a facility they might want to pursue. Or if it's somebody, that would consider a higher KDPI kidney, and they see a transplant center that does more of those types of kidneys, that they might even pursue listing there. We're really, from a perspective of trying to drive healthcare consumerism, this is what, CMS is wanting, is for patients to have information to make choices and be educated and to kind of, be in the driver's seat. So, and I think, I know a lot of people think that patients are not yet that technically savvy, but their families are. And I think we're getting into the era where more and more patients are going to be able to start looking at this and trying to figure this out. So, and I think having it mobile will be a really active and well-received application versus on a screen. So I'd like to open it up for any discussion or thought process at this point. Are you guys liking what you're seeing? Do you have questions?
I did want to add that it's going to be available through iOS and Android, so on any smartphone or tablet, as well as there'll be a way to access via computer, like a URL, like web browser. We've asked the ability to even, if a facility has to help a patient navigate because maybe they're not able to use technology like that, they can even export the information from the computer to print out for them. So there's many different opportunities for a patient to get their hands on the information, even if it's not through like a cell phone, for example.
And we did start to load it with the data that we already have from your work in Transplant Center Compare, but we recognize that there's a number of areas that are relatively new. So, there's BMI cutoffs that are being put out there more and more. There's, acceptance of patients that don't have dependency on marijuana. So if somebody is a casual marijuana user, there's some programs that will accept that. So there's some other criteria that we didn't really talk about when we developed Transplant Center Compare and Network 9. It's things we've been asking from the centers in New York and the New England states and North Carolina and South Carolina. So we need to loop back to you all and have you go through the process of letting us know, in those areas, what your program, acknowledges or adheres to. One of the others is COVID vaccination. That's an interesting point for patients, whether that's a requirement prior to transplant. So that, I think, Carolyn, you wanted to be able to send a survey back out to everybody and try to gather some of that other data and maybe some updates that you have in your own criteria. Because I know, I think Dr. Gonum was presenting on a tackle presentation the other day, and that he had a higher BMI than I think we had listed, right, Carolyn, for Ascension?
So they've actually expanded theirs to a 42 cutoff, I think is the top range. And I don't believe we had an actual number on file. And so those are the numbers that we'd really like to project, just to provide more transparency to the patients when they're pursuing transplant. And then there's other support services. So this app and this initiative is really transformed to be, what do the patients wish they knew before they started the process? And we've come up with a lot of different questions that weren't initially asked. And so we would like to resurvey Network 9 to make sure that the centers are represented to the best of their ability. And all of the great services that you do offer are really highlighted on your pages. And so some of those advancements that have been made since the original PDFs were developed, we'd like to incorporate the transplant centers in Network 9 to get the same benefit as the transplant centers in the other networks. There is a question. It's not just the Network 9 transplant centers. It's all of 1, 2, 6, and 9 that IPRO works with. So 13 states we would be on the app right now.
But it has the potential to go.
It does have the potential to go national. So people who live out of state can look in state. People that live in state can look out of state. We're hoping that's our 5-year plan, that we can expand this.
And the other area that we also need your help on is what will happen is once they do a sort, once they make some selections, they'll get turned that facility list of where facilities stand. And what we want to do is then be able to link them directly so they could click the button if it says, IU Health or whatever. They can click the button and it will come up and it'll land on a page with your image and your contact information. They have that directly and they can link to that directly. So one of the other pieces we're going to need to launch is some kind of I guess it would be a permission slip to have some imagery that we can use, whatever your standard logo is or whatever, and your contact information, so that when a person makes a choice and gets to a facility that about, they can link there. And we might even be able to, we've talked about building the podcast feature into there, that there could be a link right in. So then if they want to really learn about, University of Cincinnati, they can get onto that page, they can see all your logo, they can see your contact information. And if you had a podcast that either you wanted us to move over or update, we can link it there too, and they could listen to that about the program. So, at the end, they would be able to learn and get all the information they needed to proceed.
Are there any other questions regarding kidney transplant compare? You can either ask them here, put them in chat, email us separately if you'd like. Any question, though, I'm sure the rest of the group is interested to know the answer. So feel free to unmute and ask.
And I know Allison's coming from a dialysis perspective. Do you think this is something that in the facility you can pull up on a pad for patients and help them with? Like for those that are not, okay, so she's saying yes. So I think that social workers will actually be able to walk any patient who's not technically savvy through it and be able to use it and look things up.
Wonderful.
Other questions or ideas? Do you guys like this? Let's just, I'd like to know if this is, you feel like it's going in the right direction now. We've had a lot of iterations. So I don't know if there's anything, I think we'll be pretty much on the cutting edge that no one else is out there with these kind of information for patients. I see Allison saying sounds useful. Anyone from the transplant community, Corey or Jennifer or Jen? I see you guys on. Shelly, just wondering what your thoughts are with the mobile application.
Yeah, I mean, I agree. Sounds useful. That sounds great. We just have to make sure, and obviously, we just have to make sure that our templates are up to date, so that when people are trying to do their search engines, that we're pointing them correctly.
Definitely.
Yeah, and that, Corey, that brings up a really good point. We can manually update these at any time, but we would need, your commitment to, like, if you have a refresher, you guys, because I know, like, you were navigating the whole COVID vaccination thing at one point, but we would need the transplant centers to let us know that. We could do like an annual refresh where we ask everybody to do updates, but we could also host like what's it called? Individual requests to update if you go through a process where you're changing your criteria.
Yeah, I mean, I think I mean, yeah, you send out the updates on an annual basis. The unfortunate thing, and I just have to retrain myself, that we don't think of contacting, this group when we have a change. Not that it happens often, but we don't think of it. So I just need to retrain myself that if it's in a off cycle, that we need to do that.
Right, right. Yeah, if you're undergoing some massive change.
And Heidi put in the chat that it will be important to share with the dialysis units to encourage people to find it. So it is our full intention to talk about this to the dialysis providers and our patient groups so much that they're tired of hearing of it, and have a very robust marketing plan. A lot of effort and has been going into this project, and it's useful if it's fully utilized. And so once the app is live, that's like our main focus, is to get as many patients into it and family members into it as we can, so they could get the benefit of it and make better informed decisions about the transplant centers that they're pursuing.
And I see Joe's on, and he's our living donation expert here. Is there anything you can think of, Joe? And maybe we could even ask you about any resources. We do have a section where we talk about considering living donation. Is there anything else you think that should go into this app from an education perspective for patients?
Couple things. I mean, and I don't want to sound like I'm just promoting the tools that we're using that we have here at NKR, but and Corey can speak to this. I mean, they use the donor search tools, and they try to provide it to every patient who walks through the door. I mean, the question is, when they walk through the door, typically, is do you have a living donor? If the answer is no, they're like, well, you really need to get a microsite so that you can at least attempt to get the word out to potential, to folks, to help spread the word that you need a kidney, you need a living donor kidney. And then, if someone in your circle, family, friends, acquaintances, has any interest in being a living donor, they at least have a portal that they can go through, a doorway to register for that patient. And no one has anything to lose with that, because it's not, no one's being charged any money to use that tool. It's out there, and there's coaching available behind the scenes for those folks to help guide them with what's the best practice as far as sharing your story out there. And if you find 10 people on Facebook in your circle that each have 100 friends, and you get your site out there, you just told your story to 1,000 people. And it only takes 1 or 2 donors to make it through and get cleared for donation, and you're off to the races, and you're getting off the wait list with a living donor transplant.
Yeah, so is that microsite link something we could share? I mean, is that something
Well,
we
you
could
could
do?
share. You could share. I don't. Like, microsites have to be
Posted.
initiated through one of the member centers that's using the tool. But you could share the findakidney.org site that has a lot of information about those tools. And I can put the link in the well, it's not, if you go to the NKR main website, it's at the bottom. There's a ribbon of all the different websites that are available that talk about these things.
Right.
And I think you'll find the content to be pretty helpful.
I believe there's a brochure, an English and a Spanish one that we could possibly put on the app that talks about all of the processes to get onto that, find a donor website that you're talking
Yeah,
about.
yeah, you can use those electronic, and those brochures are available on our public site
Mm.
under the media tab. So, feel free to spread those out any way you see fit.
Perfect.
The other thing too is that I don't know, maybe it's probably too sophisticated for folks, but the quality of the match you do get is also something to consider. And there are tools that allow, if you come to the table with a donor in an exchange, you could try, especially if you're already compatible with your donor, but maybe you're not a great match. Through paired exchange in general, you have the opportunity to trade up to a better match, which we all know that, better matches lead to better long-term outcomes. So I think all patients should know about that. They should also know about donor protections. Now, NCAR is not the only group that provides donor protections. You have the NALDAC program, and I think maybe some other entities out there might offer different things to help protect the donors, like through lost wage reimbursement and travel and lodging and things like that. But I think it's important for any living donor and for potential recipients who are talking to their circle of influence, and they have people who are considering donating their kidney for them. I think it's important for them to know about all the different options out there for donor protections, including NALDAC, which is not the kidney registry program. That's a national program that's funded by grants through the government.
Yeah, and I know a lot of the states are starting to vote in some donor protection acts. And
Yeah,
I know Ohio just did a limited one, and there's
Yeah.
ones that are very extensive, like in Georgia. I know NKF's been leading a process. I think they've got something like 13 or 14 states that have donor protection acts in place. And I know
Yeah.
Dr. Goebel was pretty influential here.
Yeah, I don't know if you've ever talked with like Josh over at Waitlist Zero, but one of his big goals is lobbying for these legislative enhancements that will increase protections for donors. But
I
those
think
are things, and
I think
they've
you
had
brought up
some
a really good-
successes. Like in New York State, they had a success recently, and they got the governor to sign something. So. But they really want to try to get this to become a national thing,
Well, here's an interesting point. Allison said maybe we should put who's in the National Kidney Registry as on the criteria of the transplant centers, because then it shows you people who are, have more, exchange potentials, things of that.
Sure. And you have the NKR Center listing service, the transplant centers in Oregon. We don't just list the NKR transplant centers. We list every transplant center in the country that we know about, right? That we can see through our SRTR. That way, we're not being unfair to the non-NKR member centers, But at least people can go on there. They can make their own decisions about whether they want to be referred to one of those centers or whatever,
Yeah. Yeah. No, it's another part of the decision-making process, I would assume. I mean,
Yeah.
especially if you're interested in living donation. And I like the idea of putting some of the donor protection and some of the donor information, because if I'm looking at my phone and then I'm thinking about living donation, maybe I want to share that with somebody. Like, look up this website. You can read about this stuff.
Absolutely.
So I think that's a really good ad. Thank you. Okay.
Wonderful. All right, so if there's no other questions about Kidney Transplant Compare, we can move on to the next section. And I'm going to invite Dr. Anita Modi now to unmute for her portion of the presentation. Are you there?
Can you hear me?
Yes. So I'll switch the slides if you just want to say next slide. I don't know how to transfer that ability. I'm sorry.
Okay, yeah, no, that's okay. Thank you. And forgive me, is there a slide before this? There should be a slide before this one.
So I think actually your intro slide, it looks like it didn't make it. I'm sorry.
Okay. Would it be okay if I shared my screen?
Do you want to share? Yeah.
Yeah, okay, thank you. Let me see if this works.
While we're getting that technology up, I'll just do another call. We have a user at 216-636. Could you unmute and let us know who's on the line just so we can get attendance? 16636. Muted right now, but if you could unmute *6 or unmute. Then we have that user at the Kentucky number, the 502-341. Identify themselves. Can you unmute the 216 number, Carolyn? I can't.
I requested, they're able to unmute themselves.
Oh, okay. All right, well, if you guys can drop it in the chat even, well, if you're calling, you can't do the chat, but we're just trying to capture accurate attendance, so that would be great. 502 might be a lady from UK, the University of Kentucky. Carolyn, she said she was attending, and that's a Kentucky number.
Okay, go ahead,
Yeah,
Dr. Barney.
okay, thank you. I'm trying to see if I can share, like, not the presenter version. Do you see presenter version, or do you just see?
Yeah, we
like,
see the presenter version.
Okay, I'm going to share it like this, if that's okay. Is
Sure.
this okay? Okay, thank you. So thank you very much for inviting me to speak this afternoon. I'd like to talk a little bit about kidney transplantation, specifically in the context of a very vulnerable, albeit small patient population, HIV positive individuals. And I'll specifically be talking about the practice of utilizing organs of donors who test positive for HIV to facilitate kidney transplantation in HIV positive recipients. This is a practice with which several of us in this region, several transplant centers in this region have experienced. So to begin, I'll note that HIV positive patients need kidney transplantation. With the advent of antiretroviral therapy in the mid-90s, end-stage organ diseases such as advanced kidney disease have superseded AIDS-defining conditions as the leading causes of death in people living with HIV. These individuals face increased risk of end-stage organ diseases such as advanced kidney disease. For example, people living with HIV have a fourfold risk of advanced kidney disease as compared to age-matched HIV negative patients. And another way to put this is to say that people living with HIV comprise 0.3% of the US adult population, but comprise 1 to 2% of adults on dialysis in the United States, overrepresented at our dialysis centers. And this discrepancy can be attributed to both HIV-related and HIV-unrelated factors. So when it comes to advanced kidney disease, HIV-positive patients face HIV-associated nephropathy and kidney injury related to some of the drugs that we use as part of antiretroviral therapy regimens, such as tenofovir. As patients with HIV are living longer, they also have the opportunity to develop hypertension and type 2 diabetes, just as everybody else does. These are HIV-unrelated factors that also contribute to risk for development of advanced kidney disease in this patient population. HIV-positive transplant candidates face increased mortality on the wait list. With regards to kidney transplant candidates, this increased mortality is threefold compared to HIV-negative transplant candidates waiting for deceased donor organs. And this is in part due to longer time spent on dialysis and inadequate access to transplantation. So with that background, with that need identified, my goals for this talk are to review the history of kidney transplantation in HIV-positive patients, to discuss the HOPE Act and the practice of HIV donor positive to recipient positive, D+R+ kidney transplantation, and to delineate some barriers that have been identified to the successful pursuit of HIV-positive kidney transplantation in this country. Our story begins in 1984 with the National Organ Transplant Act updated in 1988 with specific language stating that individuals harboring the infectious etiology responsible for AIDS were precluded from donating their organs. This was at the height of the AIDS epidemic when we did not want to transmit a devastating infection to transplant recipients. But as I had mentioned, 3-drug antiretroviral therapy developed a decade later was very successful in combating this viral infection and associated mortality, such that in the early 2000s, even though people living with HIV were still not considered suitable donors, they were beginning to be considered suitable transplant candidates themselves if they developed end-stage organ disease. And the first HIV donor negative, recipient positive deceased donor kidney transplants occurred in this country. Dozens more followed, mostly to address kidney failure due to HIV-associated nephropathy at that time. These individuals were found to have an increased risk of allograft rejection, increased incidence of allograft rejection as compared to HIV-negative kidney transplant recipients within the first year post-transplantation, but with comparable patient and allograft survival at 5 and 10 years post-transplantation. So this practice was allowed to continue. The first HIV donor positive to recipient positive deceased donor kidney transplants began in South Africa with Dr. Elmi Mueller and her colleagues in 2008, largely out of necessity because of a low access to dialysis resources in that country, as well as a low availability of uninfected organs. She and her colleagues noted similarly that HIV donor positive, recipient positive kidney transplant recipients demonstrated increased incidence of allograft rejection in the first year post-transplantation as compared to HIV recipient negative transplant recipients, but similarly faced comparable patient and allograft survival. The first HIV donor positive to recipient positive living donor kidney transplant occurred in Israel in 2012, with patient and allograft survival reported 7 years later. This is the original letter to the editor published in the New England Journal of Medicine in 2010, written by Dr. Mueller and colleagues from South Africa, noting the successful transplantation of 4 individuals. And she subsequently published an article in the New England Journal of Medicine 6 years later, looking at 27 HIV donor positive to recipient positive kidney transplant recipients performed within the last 5 years. All recipients maintained well-controlled HIV without any AIDS-defining malignancies or infections reported in this cohort. 2 recipients of 27 experienced delayed graft function. 2 suffered graft failure attributed to venous thrombosis and antibody-mediated rejection. These are post-transplant complications not specific to HIV. And 1, 3, and 5-year allograft and patient survival were comparable to those outcomes of HIV-negative kidney transplant recipients on the same unit as the HIV-positive kidney transplant recipients at Dr. Mueller's hospital. So with this very promising patient outcome data in HIV D+R- transplant recipients in the United States and very promising patient outcome data for D+R+ transplant recipients abroad, the HIV Organ Policy Equity Act was signed into law in 2013, reversing the language of the 1984 National Organ Transplant Act and allowing for HIV-positive patients to serve their communities as organ donors. This also allowed for HIV donor positive to recipient positive transplantations to occur in the United States under research protocol. And in 2015, the Department of Health and Human Services published the HOPE Act Safeguards and Research Criteria, providing some guidance to transplant centers interested in carrying out transplantations per research protocol. These are screenshots of the HIV Organ Policy Equity Act, and below the subsequently published Department of Health and Human Services Safeguards and Research Criteria. These include guidance for transplant centers, donors, and transplant candidates to ensure that ultimately transplant recipients would have safe outcomes post-transplantation. So for example, transplant center guideline is an experience-related guideline stating that for a transplant center to be allowed to perform HIV donor positive to recipient positive deceased donor kidney transplants, it must have already performed 5 HIV donor negative to recipient positive deceased donor kidney transplants in the last 4 years. That's in this document. Some guidance for donors includes, it has to test positive for HIV and not have any evidence of AIDS-defining malignancies or opportunistic infections at the time of death. Guidance for transplant candidates includes, CD4 count stipulation, CD4 count greater than 400, no active AIDS-defining malignancies or opportunistic infections. That's all stipulated in the 2015 Safeguards and Research Criteria. The first HIV donor positive to recipient positive deceased donor kidney transplants occurred in the United States starting in 2016, and then the first living donor kidney transplants occurred in 2019, the first at Hopkins and the second at Duke several months later in 2019. Dr. Christine Durand at Hopkins and her colleagues began a Hope in Action consortium. This is a multi-site consortium of 30 transplant centers across the United States interested in performing these types of transplantations under research protocol, with data published in December of 2020. This group similarly found that HIV donor positive to recipient positive kidney transplant recipients faced increased risk of allograft rejection in the first year, but again, with acceptable patient and allograft survival. And we will talk a little bit more about Hope in Action and their pilot study data in a few slides. I'll just take a second to talk about rejection in HIV positive transplantation. That's been a theme for the last 20 years of this practice. Both HIV donor negative and donor positive recipient positive transplant recipients face increased risk of rejection as compared to their HIV negative counterparts, predominantly mediated by T cells, acute cellular rejection, and associated with a threefold increased risk of allograft loss. Some explanations that have been posited include the increased immune activation present in HIV, as well as variable induction immunosuppression practices at transplant centers just beginning to develop experience with this type of transplantation, and drug-drug interactions between antiretroviral therapy and maintenance immunosuppression, specifically protease inhibitors used as part of antiretroviral therapy in an earlier era, and calcineurin inhibitors still commonly used as a component of a maintenance immunosuppression regimen. Some management strategies have also been posed to address the explanations that you see to the left: maintenance of viral suppression in transplant recipients to reduce the likelihood of immune activation or the potency of immune activation as best as possible; standardization of induction immunosuppression practices, not necessarily withholding induction immunosuppression from HIV positive transplant recipients; avoiding protease inhibitors, which we do now. We're much more commonly using integrase inhibitors as a part of antiretroviral therapy regimens; and monitoring of calcineurin inhibitor levels for patients on maintenance immunosuppression. So we think that there's much more so than in an earlier era. We're starting to get a foothold on this concern about increased incidence of rejection in HIV positive transplant recipients. This is the consortium. This is Dr. Durand's consortium I referred to earlier. And I'll talk a little bit about the multi-center trial data that she published several years ago. The red states on this map house transplant centers that were a part of the consortium during the 3-year study period, 2016 to 2019. And by the time of publication, by December of 2020, the group had captured 25 HIV donor positive to recipient positive and 50 HIV donor negative to recipient positive deceased donor kidney transplants performed at 14 centers over the course of the preceding 3 years, as I mentioned. This is an infrequent practice. This is an infrequent type of transplantation, but still very important to our vulnerable patient population. I'll note that of the 50 HIV donor positive to recipient positive deceased donor kidney transplant recipients, 22 actually ended up receiving HIV false positive organs. These were truly HIV negative organs that would have been ordinarily discarded prior to the HOPE Act. Median follow-up time was 1.7 years, and the authors report no deaths during the study period, as well as no differences in 1 year allograft survival, mean estimated GFR, HIV breakthrough, opportunistic infections, hospitalizations, no difference between the HIV D plus R plus group and the HIV D minus R plus group. 1 year rejection was higher in the D plus R plus group, although this did not achieve statistical significance. This is an image depicting graft survival by donor status, and the D plus and D minus R plus groups were equivalent on that score. This is the graph depicting rejection-free survival. The D plus group faced increased incidence of rejection post-transplantation, but again, not to a statistically significant point. This merits further investigation, and that is what the group is currently doing. This was a pilot study. They've expanded and are continuing to study rejection in D plus R plus transplant recipients. As of December 31st of last year, there are 32 transplant centers in the country who have received approval from UNOS and the OPTN to conduct HIV donor positive to recipient positive transplantations. In our region, in our group here, there are 3 centers involved: the Indiana University Health, the Cleveland Clinic, our center, and the University of Cincinnati Medical Center. I can comment a little bit on our experience. We were just approved to perform HIV donor positive to recipient positive deceased donor kidney transplantation in May of 2021 and have since enrolled 3 patients, transplanted 2 of them. The first patient was actually waitlisted for HIV negative organs for a full year prior to being waitlisted separately for HIV positive organs in May of 2021. Listed for a total of 28 months before receiving an organ offer and undergoing transplantation in September of last year. He received an organ from a newly diagnosed HIV positive donor who had not been on antiretroviral therapy at the time of death, but had not demonstrated any AIDS-defining malignancies or opportunistic infections at the time of death. This patient was admitted once, a couple of weeks ago, actually, for antibody-mediated rejection. But has otherwise done well and has not had any infection-related complications post-transplantation. The second patient who underwent transplantation in December of last year was listed for a grand total of 1 week prior to receiving an organ offer from the donor who ended up testing falsely positive for HIV. So again, an organ that would have ordinarily been discarded prior to the HOPE Act. This patient was admitted twice for pain control in the weeks post-transplantation related to perinephric hematomas, which have since resorbed. Both of these transplant recipients have HIV viral loads that are undetectable and CD4 counts that have been consistently above 200 post-transplantation. I wanted to show the screenshot of the 56th meeting of the Department of Health and Human Services Advisory Committee on Blood and Tissue Safety and Availability conducted on November 17th. This meeting was in part conducted to discuss the necessity of research and experience criteria for transplant centers interested in performing HIV donor positive to recipient positive kidney or liver transplantations. There's a huge discrepancy between the number of transplant centers currently approved, that's 32, and the number of transplant centers across the country who are doing kidney and liver transplants. And that gap may be in part related to some transplant centers not being able to meet research and experience criteria. Christine Durand and her colleagues, co-investigators who attended the meeting posed that these types of transplants may be safe to do outside of research or experience criteria. so as to allow for more transplant centers and therefore more patients access to HIV positive to positive transplantation, at least for abdominal organs. So this is where it seems as though the field or this practice may be heading, at least in the United States, maybe more towards some reversal from the 2015 guidance to allow for more transplant centers interested in performing HIV positive to positive transplantation, the ability to do so. I'll talk a little bit about barriers to kidney transplantation faced by HIV positive candidates. There are barriers along every stage of this process, from referral to evaluation to listing to ultimately transplantation, some of which have been listed here. So there are provider-related barriers. Providers may be unaware of the HOPE Act and of patient eligibility for kidney transplantation if the patient is HIV infected. Providers may have stigma that limit their ability to objectively refer HIV positive patients for transplantation. Patient-related factors exist too: mental illness, insurance concerns, immunodeficiency, and perceived non-adherence with the transplant evaluation process, the inability to attend appointments and undergo diagnostic testing with routine lab work and imaging evaluations as we ask of many of our transplant candidates. All of these may prevent an HIV positive individual from successfully pursuing kidney transplantation. I'll talk about some of these barriers in turn, noting that the majority of these barriers identified have been identified through studies along the East Coast in Philadelphia and Baltimore. This is a group at Drexel in Philadelphia who conducted a retrospective chart review looking at 42 HIV positive patients from an HIV clinic in Philadelphia, deemed eligible based on the author's review for kidney transplant evaluation. Of 42, 60 were actually referred and scheduled for evaluation appointments, 60%. And only 8%, 2 individuals out of 42 were referred prior to initiation of dialysis. Only 2 were referred preemptively. Everybody else who received a referral had already been on dialysis. The median time from meeting eligibility criteria to receipt of appointment was over a year. Marked delays in the referral process is, I think, what this highlights. And 20 out of the 25 individuals who were actually referred attended their initial evaluation appointment. 2 out of 25 rescheduled and attended a subsequently scheduled appointment. 3 did not proceed with evaluation even after referral, 3 out of 25. This group noted that patients without appointments, so the 40% of individuals who did not receive appointments, even though they may have been eligible candidates, more commonly demonstrated schizophrenia, history of viral resistance, mostly to protease inhibitors, which were more commonly used in that era, that study period, unemployment, and substance abuse history. Barriers between the evaluation and listing processes were similarly described by the Drexel group, looking into 105 HIV positive individuals evaluated who were actually referred and evaluated for kidney transplantation. The majority of individuals in this evaluation had developed acute kidney disease, advanced kidney disease related to hypertension or HIV-associated nephropathy. 24% were co-infected with hepatitis C virus. 16 had a history of opportunistic infections, and the median time to evaluation from the time of HIV diagnosis was over a decade. The primary outcome of this study was looking into listing for transplantation. 73 of 105 were listed, and 10 out of 105 were ultimately transplanted. The time to listing was noted and longer in HIV positive transplant candidates versus 99 HIV negative transplant candidates evaluated at the same center and used as controls. 160 days versus 95 days to complete an evaluation or to go from the start of evaluation to eventual listing. The delays in HIV positive transplant candidates were attributed to non-compliance as defined by the transplant center. Cardiac evaluation, need for cardiac evaluation, more common in this patient population, and insurance issues. Of those who were deemed ineligible for listing, the 30% of the 105 who were ultimately not listed, the most common reasons included active substance abuse and inability to complete the requirements of the evaluation. I think, I'll just take a step back and say some of these terms like non-adherence to the evaluation or non-compliance or inability to complete the requirements of the evaluation, these may speak to the socioeconomic barriers and other issues going back to things like mental health issues or insurance concerns that may be able to be addressed by some of our transplant centers if we're able to apply the right resources. So I wouldn't necessarily consider that language a hard no or something that's totally insurmountable to provide the same opportunities for these vulnerable patients. These pie charts depict essentially what I described previously, what the authors have noted, the main reasons why 30% of individuals were considered ineligible for listing included active substance abuse and perceived inability to complete a workup. The main reasons cited for delays in the evaluation process included perceived noncompliance, increased need for cardiac workup, and insurance issues. And finally, I'll just comment that the main barriers between the stages of listing and transplantation include some things that we've already discussed, maybe certain research and experience criteria imposed by the Department of Health and Human Services early on in the early days of this practice in the United States, which may limit a number of transplant centers from being able to participate and offer these types of transplantation at their programs, at their centers. And the other main barrier relates to the national organ shortage and specifically a decreased likelihood for HIV positive individuals to serve as organ donors as compared to HIV negative individuals within the community. And that's also been studied, and the main reason for that, just as there's provider lack of awareness about the HOPE Act, there is patient lack of awareness about the HOPE Act, and the majority of HIV positive individuals in our country are still not aware that they can serve as eligible organ donors. So and that's on the HIV side, that's on our side to inform our patients at clinic that they are able to register as organ donors and maybe help bolster the donor pool. And some of the work that I was talking about with the advisory committee, easing some of these research and eligibility criteria now that we have the data to suggest that this type of practice is safe, may allow for transplantation to be offered more broadly across the country, address some of those barriers towards the end of the transplant process. So in conclusion, I'll just say HIV positive patients need transplantation, and these can occur with excellent patient and allograft survival, although we are still looking into reasons for and strategies to reduce allograft rejection in HIV positive transplant recipients. And these individuals face barriers in healthcare in general, but specifically in the kidney transplantation process. And I think one of the things we can do is remain aware of these patients' eligibility for transplant candidacy and utilize the resources of our individual transplant centers to help overcome barriers specific to this vulnerable group. I'm happy to take questions or comments.
Thanks, Dr. Modi. I had one question. This is Vicki. How many patients approximately are out there that are across the nation that
Sorry, you're cutting in and out a little bit. I couldn't hear your whole question.
Oh, I just wondered how many patients across the nation are living with HIV and ESRD.
It's 1%, 1 to 2% of the entire ESRD dialysis population.
So if there's 750,000, there's something like 7,000 patients out there in the nation.
That's what's been estimated. That's what's been estimated based on HIV Research Network data.
And is there like a map of the facilities that take HIV positive patients, like across the country? Is it all those ones that were in red in the HOPE Act?
So this is the most updated one. The ones in red, the ones on the map were from 2016 to 2019. These are the ones that on the slide that I'm showing now are the ones able to perform donor positive to recipient positive transplants. But any transplant center can perform donor negative to recipient positive transplants if they feel comfortable. There's no stipulation on that, or there's no additional approval that's needed for that practice.
I see. There's a lot of states missing here. Huh?
Agree. Yeah. And part of it may be because there may not be the resources at smaller transplant centers to put together an IRB approved protocol and have a research coordinator and get together a data safety and monitoring board to facilitate these types of transplants, which is what's required based on the 2015 DHHS safeguards and research criteria.
Very interesting. Thank you.
Dr. Modi, I have a question. So you mentioned that, education for patients and providers alike is necessary in this area. And we just got through kind of talking about our patient-facing application that has education on there. Do you know where we could find education for patients and their family members regarding the HOPE Act or HIV positive donor recipient transplants?
Yeah, I can send links after this. The majority of patient-facing educational material has been produced by Hopkins, and it's all publicly available. And these include flyers for HIV clinics to post, in office spaces, reminding HIV positive individuals that they can serve as organ donors. So there's Hopkins produced information about organ donation and transplantation for HIV positive individuals that I can send after this.
Okay, thank you.
And does that have provider information?
I can look at that. I can look at that too. I know for sure that we've been using patient-facing information. I'd be surprised if they didn't have provider-specific information too. I can look into that.
Are there any more questions for Dr. Modi regarding her presentation? Awesome. Okay. Thank you very much for coming and for sharing this information with us. We have about a little bit left in this call, so I'm going to move on to our next presentation. Just give me 1 second. Okay, you see Radiant updates on your screen now. All right, so I'm going to introduce Dr. Rachel Patzer. She's part of the Radiant study team down at Emory University, and she's going to provide Radiant updates and talk about some timelines and the dashboard for the study that I'm sure you all have heard about at this point. Go ahead, Rachel.
Great. Yeah, thank you. Thanks so much for having me. And I'm at Emory now, but I'm moving to Indiana University and the Regenstrief Institute in less than a couple of months. So I will actually be officially in your network. So really excited to join the IU team. and continue some of the research that we've been doing, expanding some of our work looking at early access to transplant and reducing inequities in access, not just in the Southeast, but in other regions. So do I have control of the slides, or can you want to go to the next slide?
Go ahead and let me
Caroline,
know.
you've got it.
I'll switch
Great.
over, yeah.
Okay, so great. So what we've done as part of this rating is the Reducing Disparities in Access to Kidney Transplantation study. It's a mix of quality improvement and research, but we've really been doing this for almost a decade in the Southeast, and have expanded it to more than 30 transplant centers across the 4 IPRO networks. And so we're going through our next round of data collection, looking at collecting data on referral and evaluation start, and some information sort of on the pre-waitlisting side. And the kickoff meeting, I don't know who all was there, but that was held in November. We sent out a recording for those who couldn't attend, but just really updating people on that project. Network, so of the 4 IPRO networks, actually network 9 has the lowest participation in this project. You know, I don't know what all the reasons are. I think it's partly it does take some time for that first initial data upload. So we had 4 of your centers participating in your network. We actually have all of our transplant centers in network 6 participating. And what we did find at the beginning was that, you know, at first it was just a few centers who did it, and then they saw the value of the data collection and how they were using the data. And so they've continued to submit from year to year. So we would love to have more representation from Network 9 this year, and I'm going to show you, hopefully we'll have time. I know we only have about 15 minutes, but I want to show you at least a preview of the dashboards. I also just sent in the hour before, I was multitasking in another meeting and sending you out an email. Hopefully you all received it, but it has a link to the public facing dashboard. And by public facing, I mean it's the only people who have this link, but there's no center identifiers in it. But to give you a preview of what some of the things we're doing with the data, or how you could use that data to help improve access to transplant. We are working on, and we have a mock-up pilot version of a transplant center specific version where you can log in and access it and have some specific information on referral and evaluation for your network. Some of you have used those in the past in the Tableau reader version. If you've participated, if you're one of the 4 centers, we're changing a little bit of how we've done that because the Tableau report was maybe less accessible and useful. And so this is going to be hopefully more accessible for people. So hopefully in the next week or 2, we'll have something we can send out for the centers that have already submitted data to show you. But at least in the interim, we want to show you the what we've done with the data so far and what you might be able to do with that. And of course, Anne Hummel has been really engaged in this, and she's been involved in kind of helping to participate and giving feedback on the dashboards too. And we really appreciate her as sort of the transplant champion of this project for your region. So the next round of data collection for centers, there's still time. It's March 17th. So it is coming up pretty quickly. I'm sure you've gotten multiple emails about it, but we'd love to have data submitted for that project for this round. If you want to go to the next slide, Caroline. This is a preview of the dashboard. So this is an interactive dashboard, and in a moment I might see if we could bring up that link. I don't know if it would be too hard for you to go through, Caroline, the link itself, where I can share my screen and go through the dashboard myself, or Jade could do that. But the dashboard, again, is in your email, and somebody could also, if Jade, if you're here, if you want to put it in the chat, the public facing website, just so people have it handy and can click on it to explore. But in the top, you can look at different outcomes, whether it's referral within 1 year of starting dialysis or of diagnosis, evaluation start or lifting, and some of those steps in the transplant process. You can select which, whether it's all the IPRO network regions, whether it's your own network region. You can exclude preemptive patients or include those who were referred prior to the dialysis start, and look at different dates and times. And so you can go to the next slide. This is just one of the example figures you can show over time. This is showing the monthly percentage of incident or new patients within a facility that's referred within 1 year of starting dialysis. This is for Network 9. So this is for the 4 centers who submitted these data. This is the data that we see. So this ranges from month to month, but somewhere between 17 to 25% or so of incident or new patients are referred for transplant to one of the transplant centers. This may not be an accurate estimate because we don't have all of the data from all the transplant centers. So the more transplant centers that participate, the better we have on data on referral. We do have really good data on once patients are referred that starting the transplant eval, since that's mostly within a center. So I don't know if you want to go to the next slide. Some of the other demographics and characteristics that we also show in the reports. You can look at the demographics of the patients that are referred and compare that to not just your own center, but this is showing it your network. But the mean across all 4 networks. You can go to the next slide. We don't have all of these here. Percentage of patients who start the evaluation. So this is accurate for the 4 centers who do submit data. It looks like, I believe we have a median line added in here now that we just added in the last, we're working on this every day to try to improve the dashboard. Our research team is, but looking at the center level variation in the proportion of patients who start the transplant evaluation within 6 months of those, among those that were already referred. So that ranges from 48% in one center to 66% in another center. Again, it's really helpful when you have all centers participating in the region, then you can kind of see what some of those differences might be across your region. You can also go and see what does that look like across the other 4 IPRO network regions. And these are data that are just not available in national surveillance data, so hopefully helpful. You can go to the next slide. So this is just more information about the dashboard, which we've already shared the link, but if you want to do that, the point of contacts, our email addresses as well. And then if we have time, I don't know, Caroline, how you want us to do it to go into the actual dashboard. But
Yeah, I would say you or Jade can share your screen and use the remaining time to go through the dashboard, and we can do the discussion questions in a follow-up with the group. That'll work just fine. I think that showing the dashboard would be important for engagement in this.
Okay, I'm gonna try to share my screen then. I just need to find, I have a lot of tabs open. So give me just a minute and see if I can share the screen.
One of the barriers, what happened here was at the time that we went to get the data was like right on the beginning or the end of the pandemic. My head is fuzzy now, but I think it was like right when the pandemic started, and then everything fell apart, right? And then after that, no one had data for so long, so it all kind of went into a, just a grind, right? No one saw anything, and people forgot what it was even about. So is there still assistance with the data? Is there still financial assistance to build the interfaces, or is that gone now, Rachel?
Well, technically it's gone. If for some reason that the reason why you're not doing it is because of the finances, we probably could come up with the funds to do it. It's a little complicated because I'm trying to move some funding from Emory to IU, and we have a place where we can't spend any money for a few months in order to move it. But I think we can work that out on a case-by-case basis, even though that deadline is passed for the support. So I believe it was $4,000 per transplant center, and I think we will figure it out if that's the barrier. And the intent was for that to cover about 1 day of someone in IT, their time to pull the data. Everybody that we've worked with, it's been pretty reasonable. That we had one transplant center in Network 6, I would say that they, at the start of this project, didn't have they had their data, not a very small program, didn't have electronic medical records, had a lot of paper forms or things that weren't stored very well, or you had other programs that don't have historic data. So there are some cases where it's more complicated, but for those that have like Epic or Cerner or Otter, the data is really accessible, and it's data that is all in the electronic medical record. There shouldn't have to be any entering that data by hand. It's just a pulling of the data through the electronic medical record.
So it's really kind of like a day's work. Is that kind of where you see it, like a data?
Yeah, I mean, right now, for those who have already submitted the data, it should be like 30 minutes because they've saved the query and they run it, and it's not long at all. But for the first one, we've heard a range anywhere from an hour to 8 hours, depending on what the situation is with the electronic medical records or who the person is and how familiar they are with the data. We've also had some back and forth, so there's always confusion from the transplant programs. They think at first that we want among their transplant recipients, their date of referral, and that's not it. We want anyone that came into the to the program, including those that were referred and never even started the evaluation, or they were referred and then never even got waitlisted or transplanted. And sometimes we have some back and forth that takes additional time because there's confusion on that, or the way they pull the data is often they think about their transplant recipient population, whereas we're thinking upstream. We're trying to figure out who maybe was referred but never even got on the list or ever got transplanted. Are you guys able to see my screen of the dashboard?
Yes, we are.
Yes.
Okay, so this is the website, and you can see there's a little bit of information and background on the first page, a little bit about the definitions and how we're getting some of the data, how this is defined. And then you can go in on the left and click on the actual dashboard, the interactive dashboard. And I'm going to focus on, so you can see at the top kind of where you are. So if you want to look at referral, you can click on referral. If you want to look at, evals start within 3 months versus 6 months, depends on kind of, there's some regional differences there and what might be the relevant time point. So it may help to look at one versus the other. I'm going to look at network 6 where we have complete data for a moment, and then I can look at network 9 in a second. But this can show for all of our transplant centers in our region that submit data. I see that I'm in this region. This is showing me the proportion of patients starting the evaluation within 6 months. And I see the median is 61%, but that ranges from 48% to 74%. And then I can look at some of the demographics and click across age, sex, ethnicity, and then do some comparisons of what does it look like for my network versus the rest of the 4 networks in IPRO. The only comparison we really have. Race, I know that, in the Southeast, of course, we have 58% of our patients who started the eval within 6 months among referred were Black or African American, and that's higher than the other 4 networks on average. Look at insurance status. There's some other things that we're looking at. We have a lot of ideas for a dashboard 2.0. So we're calling this really our pilot, but this is hopefully meant to be something that would be helpful to transplant programs, especially when you're able to log in and see, okay, which center is mine? And that's one thing we're trying to figure out, just the logistics of the login for that and some of the information you might want to see. This is showing that monthly percentage of patients starting the evaluation within 6 months of referral over time. So it might be helpful to look at trends over time. Overall for our network, it looks like, there are times when we have dips, but overall it looks like it's been fairly steady. There is some seasonality there, but sometimes helpful to look at, what does that look like in network 6 versus what might that look like in network 9? Again, we only have 4 centers, so it's a little bit harder. We don't have quite enough data to be able to look at some of these trends overall, but you can look at, what's the age distribution and how does that compare to the other regions. I'll look at the race distribution since I just did that before. 32% Black or African American. Again, this is among those that were started the evaluation within that time period. You can look at the eval start rates. Looks like there's kind of a decline over time that among the 4 centers of that eval start rate among those that are referred. One of the other things, maybe I'll click real quick on one of the other outcomes. So let's say waitlisting within 6 months of evaluation start. So among those that did start the evaluation, what does waitlisting look like? And again, we do see differences across the center. The median was about 55% of those are put on the waiting list within 6 months of starting the evaluation. And then you can go in and see there are differences. You can see in the proportion by demographics at each step of the transplant process, which can be helpful. And then monthly percentage of waitlisted patients, fairly steady, it looks like, over time. Harder to say if this drop here, this was 2020, June of 2020. So, we definitely see some dips. We're seeing a lot of discrepancies or dips or interesting results in 2020 for obvious reasons with COVID. So in our next round of data collection, what we do is we'll take this and then link it with USRDS data. So we have appropriate denominator data, validate the waitlisting data, account for deaths that may have occurred that we may not, that transplant centers may not be able to capture. But this is all captured in the dashboard. This is also exploratory, but this is one of the things that this is showing de-identified, but we're really excited about some of the patterns here of where referrals are coming from, these maps. And so the big purple stars here are different transplant centers. This is geographically hidden, so you don't know which centers these are, where these are coming from, but the pink lines are showing you different referral patterns, and then the referral patterns over time on the right. So that's just a mock-up for now. It'll that ideally, it may take us a little bit more time to do this, but we'd love to show you that for your center, where are these referrals coming from, sort of visually. And that then what you can actually do is you can go in and you can zoom in on these and see where did that referral come from, and learn more about what that what's going on at that dialysis facility. So I can look down at the zip code level. Okay, I know that there's 18 patients in this in this dialysis facility, and presumably if I knew this was my center here, I might want to know where my referrals coming from. Where might I want to target outreach? So one of the other things that we're trying to work on is a dissemination type of video for, how can we have people use these tools, and what are the best practices for how they might want to use the dashboard or the tools to improve access to transplant. We also have a lot that we have planned to look at equity metrics and other things like that in the dashboard that we're working on. And I know we're at 4:31, so I'm going to stop, and I don't know if we have any time for questions, but hopefully we do. I'm happy to stick around for a couple minutes, if so.
So I had one question. Can you, more than one network, can you see all the bars like across? Like if I picked network 6 and network 9, would it merge all the bars together so you could see?
Right now, so in the dashboard, we have it where you select either all networks or you select one network. It's something we could do, is make it so that you can just select 2 of the networks instead of just one or just all 4. So we can write that down as something that in a future iteration, that if you want, you could check off a box rather than just have to select one network or all 4. But right now we don't have that functionality to compare to.
And are you able to put any time windows in? So like if you wanted to see if your referral for race and workup was going better, like let's say you wanted to see if you were improving, put a time window in to see that, like last year, we just got this many referrals in this race.
Yes. Yep. I think you're cutting out a little bit, but I think I understand. So the timing right now, we're showing this right across all the data that we have. But yes, that is the plan, is that you'd also be able to say, well, show it to me just for the last year. Some of them it's a little complicated because we're looking at, we need a lot of follow-up time to be able to look at like waitlisting outcomes. So for example, we have to have enough follow-up time that someone in the data period that we collected, they had a referral, an evaluation, and waitlisting to be able to have enough follow-up time to be able to estimate that. So we kind of have to think about how do we best do that. It's not as clean to just say, show me what happened in 2020, because of the different follow-up time you need for each outcome. Does that make sense? Yeah.
Yeah, I get you.
But
I think it's fascinating. I think it's
yeah.
Hope we can get more.
I also just wanted to add that we are also able to track analytics and usage of the dashboard, and track like locations of who's using it, which pages are being used most frequently, and time spent on those pages as well.
And is it scaled to become national if that was ever the intent?
We would love to try to do this nationally. It's just going to take policy change most likely, or a lot more funding to be able to do it. I mean, we try to support this with grant funding as much as we can, but that requires a lot of effort. So hopefully we'll continue to sustain this with grant funding. We keep trying, and the IPRO team really has done a ton of work for, as serving as the data coordinating center for this effort, and how we try to support the IPRO team and the data team, Svetlana and Caroline with all the communications and management, plus our team that's doing some of the data and analytics. It costs money to fund some of that, but I think the hope is that we continue to at least support our 4 IPRO regions to do this on an annual basis. At some point, it'd be nice to do it more regularly when we have it more seamlessly kind of figured out, but we're not quite there yet. It's taken us a little bit more to launch, to go from our now 10 centers in network 6 to 30 plus centers in all 4 regions. But I think that would be the longer term goal.
Well, I just was on an NKF presentation, and she was speaking about how it's such a black hole about the referral to evaluation and to waitlisting. And, I brought up the project because I know you guys have an NKF representative on your,
we do.
on your work. And so I was saying that this is a project that's working to open up that, and create that visibility. So
great. Yeah. There's a lot of national conversation right now about the importance of this data. I sit on the ASN Policy and Advocacy Committee, and this is being presented to the Hill on as like a top priority area to have data collection on this on a national level. But there's just a lot that goes into that, and there's a lot that's, you know, should it be CMS, should it be HRSA and OPTN? I think there's debate about that, but hopefully we'll see some movement. But in the meantime, this is the only source of data that there is on this black hole of these steps and what's going on with the transplant process. So I think it's really important. And what we've been able to do in our network is then take this data and use it for interventions and other quality improvement activities. So hopefully it's something we can do across networks.
Does it include preemptive transplant, people that go from CKD? So your data is inclusive.
It does. Because we collect the data from transplant centers, we have anyone that received a referral at all. So, and was waitlisted or evaluated, or transplanted. So even if that happened before, the preemptive transplants, we don't have anything that's showing transplant right now. We certainly could, because we have that data through USRDS. It just, again, there's a data time lag. So it's a little harder to get at transplant dates, or transplant data in a timely fashion.
But we're just seeing a real rise in preemptive transplant, and, you know, people getting transplants pretty early on and not even going to dialysis. So just even at, you know, ESRD stage 5. So it's just an area where we want to start catching that kind of data, like who's able to move like that so quickly into transplant.
Great. Yeah. Okay. Good. Well, hopefully more to come, and we're open for feedback on the dashboard, or anyone can feel free to reach out to us with any questions or comments or anything. But yeah, I'm looking forward to joining your network and staying engaged in this project. So hopefully I'll see more of you again soon.
Wonderful.
Thanks.
Thank you so much, Rachel. I think that concludes our meeting for today. I'm going to send the recording out to the group as a follow-up with some discussion questions to see if we can generate some more topics for the future for this the rest of this year. Thank you all for joining, and I hope you have a good rest of your week.
Thanks, guys. Bye.